When you hear the words emergency management, you might think of disaster response teams or crisis drills. But in nursing, emergency management refers to the care we give to patients with urgent or critical needs. That being said, in the real world, the emergency department isn't just for heart attacks and strokes. Because many people don't have reliable access to healthcare, the ED often becomes their only entry point into the system. That's why the philosophy of emergency care has shifted. Today, an emergency is not only defined by lab values or vital signs, it's defined by what the patient or their family considers urgent. So what makes an emergency nurse unique? These are professionals with specialized training in assessment, critical thinking, and rapid prioritization. They monitor patients who are acutely ill or injured, support families in crisis, supervise other team members, and educate patients, all in a high-pressure environment where every minute counts. They don't work in isolation. Nursing and medical roles are complementary, and interventions are anticipated based on assessment data. At its core, emergency care is team care. Patients come to the ED for life-threatening problems: arrhythmias, acute coronary syndrome, heart failure, pulmonary edema, and stroke. Trauma and conditions not covered elsewhere in the medical record also land here. The bottom line? Emergency nurses are trained to expect the unexpected and act quickly. Documentation of consent and privacy. Let's shift gears. One of the most important responsibilities in the ED is documentation. Consent to treat is part of every emergency record. Patients must give explicit consent before invasive procedures like lumbar punctures or angiography. The exception, of course, is when the patient is unconscious or unable to make decisions, in which case care is provided and documentation must reflect the situation. Every intervention, every medication, and the time it occurred must be charted. After treatment, notes include how the patient responded, their condition at discharge or transfer, and what follow-up instructions were given. Privacy is equally important. By law, patients receive a copy of the hospital's privacy policy. Special measures are taken in cases involving violence. Patients can be assigned an alias, or their electronic record access restricted. Under HIPAA, patients can also request extra privacy, limiting visitors, phone calls, or deliveries. EMTALA, the Emergency Medical Treatment and Active Labor Act, also comes into play. Any ED that accepts Medicare must screen and stabilize every patient who presents with an emergency complaint. If transfer is required, consent and acceptance by the receiving facility must be secured, and documentation travels with the patient. Limiting exposure to health risks. Emergency departments are high-risk workplaces for communicable disease exposure. Blood, respiratory droplets, and body fluids are routine parts of care, especially with invasive procedures like wound repair, suturing, or intubation. Historically, nurses have been at risk from hepatitis, HIV, and tuberculosis. More recently, COVID-19 brought these risks into sharp focus. Because not all infected patients are symptomatic, universal precautions became essential. Everyone, patients, visitors, and staff, is screened. Masks are required, and healthcare workers must wear hospital-grade protection, not bandanas or cloth coverings. The Emergency Nurses Association emphasizes that emergency nurses caring for suspected or confirmed COVID-19 cases must be supplied with appropriate PPE, like N95 respirators that filter out 95% of airborne particles. This equipment is non-negotiable. Beyond infections, ED staff may also be exposed to hazardous chemicals, gases, or even radiation, particularly during disasters or terrorist events. Early identification of risks and strict adherence to safety protocols are the first line of defense. Violence in the emergency department. Finally, let's talk about violence. Unfortunately, aggression toward ED staff is not rare. Patients under the influence of drugs or alcohol, individuals with psychiatric disorders, or those caught up in social situations like gang disputes may act out violently. Stressful wait times and overcrowded conditions only add fuel to the fire. That's why safety comes first. Security officers, silent alarms, and metal detectors are standard in many EDs. Sometimes, rival groups or families need to be separated to prevent confrontations. And while verbal abuse is the most common form of violence, physical threats can escalate quickly. Nurses must be prepared to use both de-escalation techniques and, when absolutely necessary, safe restraint practices. The Joint Commission requires strict documentation when restraints are used, with monitoring for both safety and dignity. Precautions include never releasing restraints on incarcerated patients, maintaining distance to preserve staff escape routes, removing potential weapons from the room, and avoiding items like dangling jewelry that can be grabbed. Some facilities train staff with de-escalation and restraint courses so they're better prepared.